Welcome to the EMT Pro podcast, where we deliver relevant EMS content from the field and the classroom each week. I'm your host, Steve, and with me I have co-hosts Dan and Holly. Guys, say hi.
Hello, sir. How are you?
I'm doing well. And just as a reminder, each episode of this podcast gets everybody 1 full hour of CE through our partner, emt-ce.com. So head over there for more information. Excited about today's episode. We're going to be talking about Airway, which is, I think, even BLS and ALS providers favorite topic for the most part. So I guess Dan, where do you want to start with today's episode, and what you want to start with a case study? Do you want to start with?
I do.
Okay.
I do. I have a good one that's I think will shed a little light on this.
Perfect.
So I work at the fire department, and I was working on a fire-based medic unit, and we don't transport at this particular station. And so it's my partner and I, we're going on a motorcycle accident on a large highway, and we have a private ambulance coming, and they are the transporting agency. And so it's just the two units coming to this because everything else is super busy. And so we arrive, motorcyclist was struck from behind by another car. He did have a helmet on, but it's one of those little skull caps. And so he had a head injury going on.
Okay.
It wasn't strapped on very well. And so he's unconscious, unresponsive. The transporting medic pulls him right behind us. So we do rapid C-spine onto the gurney and get in the back of the ambulance. We're probably 15 minutes away from the trauma center, level 1 trauma center.
Okay.
This was a point in my career where I would RSI anyone and everyone. Oh, your finger hurts. Okay. I'll stand by.
Yeah. Let's take your airway.
Let's take your airway.
Ground level fall, get in a tube.
Get in a tube. So all it would take at that point in time is me to go to the next exit, flip around, go back, bypass all the traffic, and get to the trauma center within 12, 15 minutes. I probably should have done that.
Okay. Yeah.
But we pulled to the side of the road, let the traffic go by, and we are going to RSI this patient.
Okay.
Which at the time I thought was a great idea. So I'm working with an inexperienced medic, and then the two medics on the ambulance were very experienced, but they're still in the same groove they've been in for 30 years. Mm. So we start the process, and all we did, we're going to push drugs and put the tube in. So his SATs were like 89%.
Okay.
That didn't even faze me at all.
Okay, so did you pre-oxygenate?
Nope.
Did you nothing?
Nope.
No, we needed a tube.
Nope. Got to get this tube.
Wow. Okay.
I got to get this tube so I can get back and get some food.
Right. Yeah. I mean,
Right.
it's probably mealtime.
Right.
Yeah.
So, okay. So let's just do this. I'm going to get the airway because I have to get the airway because I love getting the airway. So I'm in the airway seat, position myself appropriately, making sure they push in the drugs. I got my tube ready. No one's watching the monitor. No one even knows what the SATs are. And I go in, and this is before we had video laryngoscopes.
Okay.
And I look in there, and all I see are holes.
Holes.
Like, which hole do I put it in?
Yeah.
I guess not that one. So I put it in this one.
Okay.
Okay, it was the wrong one.
Okay. So
Esophageal.
Okay.
Right. I did have sense enough to put on the end-tidal CO2.
Okay.
Did you get a blood pressure?
Didn't get a blood pressure. Who needs a blood pressure?
Who needs one of those?
Who needs that? Right. And so, okay, I guess I'll pull the tube out. I was pissed. And so I pulled the tube out and didn't even look at the SATs. I mean, it's a traumatic brain injury. What are we thinking traumatic brain injury?
Oh, a lot of things.
Right.
Yeah.
Those SATs go down below 90 is...
Oh, yeah.
Yeah.
Well,
possibility of
mortality. Cushing's and everything else.
Mortality, right.
Yep.
So we don't even really bank him up. I just position something else, do something different, and put the tube in. Looked at end-tidal. End-tidal was, 38 or whatever. I look at the SATs. The SATs are 64. So
Jeez.
64. And this was a relatively healthy young guy.
Yeah.
Where there was no underlying lung disease.
Mm-hmm.
So what did I do? I high-fived my partner because I just got the tube.
Right.
Ooh.
Yeah.
Strong
Yeah.
work.
I did a
Strong
great
work.
job.
And
All
I
right,
mean,
let's go.
did you just start hyperventilating at 30, 40 a minute?
Well, I mean, the title was right where I wanted it. So,
Okay.
right. So, I gave it a little high five. All right,
Yeah.
let's go to the trauma center now. 15 minutes later, we would have been there.
Right.
Had we just transported and just controlled the airway as best we could. But we did deliver him with SATs in the 90s after I've ruined his brain with SATs in the 60s.
Mm-hmm.
But at that time, I had no idea.
Yeah.
No idea what I did.
Yeah, I mean, I remember going through medic school 12 years ago or so, and the idea of impressing pre-oxygenation was definitely in our curriculum. But it was, I remember the 6 or 7 Ps were brand new.
Right.
Like that whole pre-oxygenate, prepare, don't ask me what the
It's
rest
like
are.
the 5 H's and 5 T's. You
Put the
can't
tube
remember
in.
them all,
Yeah.
right?
Right. For testing
Right.
purposes, but
Yeah.
to actually do them.
Right. And I hear you. It was not uncommon looking back during my volunteer years, which were a few years prior to paramedic school, and in remembering calls where, man, they just didn't think about that stuff because it wasn't, as long as you got the tube in the right spot and you got the SATs back up into the 90s, a little
Success.
a little hypoxic episode,
Yeah.
that just comes with the territory.
And we never worried about blood pressure.
No.
That was never a consideration to
Ever.
resuscitate before you push paralytics.
Right. Yeah. And then I remember, the permissive hypotension debate, which became, actually something we should be doing. I remember traumas back then being 2 big bore IVs and just
wide
run
open.
it wide open until you get the pressure you want.
How many bags can I get in there before I get to the trauma center?
Yeah. Oh man, I think I get at least 2.
Right.
At least 2.
Right. I'll sit on this thing.
Yeah. Oh man.
I feel like when I went through paramedic school, I learned how to intubate we never medicated for pain or sedation.
Nope.
First of
Right.
all,
That was never impressed.
I was never impressed. And then just stick the blade in there until you see something and pull back.
Mm-hmm.
That's how I was taught.
Same here.
And we never positioned the patient because we just wanted to intubate under the table or the semi-trailer or wherever, because that wasn't an option.
Right.
Or it wasn't impressed upon us to make our first attempt our best attempt.
I remember taking that difficult airway management course 5 or 6 years ago, and just having I remember just feeling like, oh my gosh, why wasn't so much of this stuff just baseline paramedic knowledge in a book somewhere? We're talking about positioning. We're talking about intubating in all these weird spots that we could potentially be called to intubate. I've had a few. I haven't had like really crazy ones. I've had a couple that are pretty out there, but upside down in a vehicle, haven't done that one. But
you know what's wrong with those courses is we need a course where it's not the difficult intubations, it's the intubations.
yeah,
Because we
just doing it
intubate
right.
way fewer patients than we did back in the day. Because now we have iGels and Kings and such. We're popping
Right.
those on cardiac arrest. And then the CHFers are getting CPAP. And so
Right.
tube delivery is way down. And so our practice is way out.
Yeah,
So
And I think the areas where we all work, there's several paramedics on scene.
Correct.
So the chance of you getting that tube is pretty low unless you're first on scene and can
very
stake
true. You
your
have to
claim.
position yourself.
true. yeah. I've got friends who are known for, look who just decided to sit in the airway seat
Yeah.
right when they needed
Yep.
to. Yep. And
And I'm kind of that
they
guy.
just giggle at you. Yeah, I know you are. Yeah.
But let's see, I'm trying to be more of a mentor now as opposed to someone who does the work.
Right.
But then you just sit there, you get so frustrated.
pissed.
Like, dude, we just went over this in drill today.
Yeah.
Position the patient.
Yeah. Just do it
I got
right.
it. Get out.
Yeah. You know what? Just move. Yeah.
I think another thing that was ingrained in us when we first came up in this EMS business was, I don't know how to say this, but checklists are for dummies.
Right.
If you can't just do it right off the top of your head, you're an idiot.
Yeah.
And so checklists were never a thing that we used. Even the dosing cards.
Right.
When those came out, it was just trying to get people to use those was kind of a big deal.
Right.
Because you
Unless you're
didn't
a
want to be
fighter
the
pilot.
one to pull out the dosing card, right?
I remember I was on probation with my fire department, and they had just released a binder of COGs for the first time. Like they had them in printed form, but like they were not distributed well. And they finally like got this out into people's hands. And I was like, oh man, I could make this into a flip book. So I took it, shrunk it down, had it printed, and everybody was like, yeah, dude, I want one of those. I was like, okay, cool. So make a big order. Everybody, chips in or whatever, and we get them, because management wouldn't do it because their thought was, well, we don't want you guys in the heat of a moment looking something up.
Exactly.
And it's like, why not?
Isn't
that what you want us to do? Like, if we have a question to be looking something, obviously we're not going to be taking the chest pain protocol out when someone is experiencing chest pain. Like, hang on, let me ask you this question next, and then this question, and then this question. Like, it's not like that. It's used as a reference for those low frequency, high risk events, right?
And if you're in the ER, you're never going to walk into a code or some sort of resuscitation without someone having a checklist or two out.
Absolutely. They're all over the place.
We don't start up the aircraft without a checklist. We have checklists for everything on that side.
Yep. So can we go back?
Yeah, let's go back though.
So let's start at the beginning. Like, why did I intubate that patient?
Yeah, let's talk about it.
I'm super close to the trauma center.
Right.
I'm understaffed. There's only 4 people on scene.
So Dan, this is the stuff that gets me excited because I like the mental side of what we do. Like,
right.
Because
it's all different.
It is.
If we get out, like when I teach our new people at the fire department, I will take the protocol book, I will open the door, and I will throw it across the street because it's just a guideline.
Yeah.
And people just take that thing and they just go. My kid, when he was 12, could have been a paramedic because all he has to do is just read down the protocols. So you got to critically think each one of these calls and each one of these patients. And so that person, that tube was all for me. I was bored that day. I needed something. Yeah, this guy needs a tube. He's going to get it eventually, so why not have me do it while his brain is, becoming so huge inside his skull.
Right.
So.
So you wanted to intubate this guy?
Oh yeah.
Did he have a mental status? Was he breathing?
He was breathing.
Tell us about him.
Yeah, he was breathing. His SATs would have been 100%. Had I just put an non-rebreather on him, controlled his airway, had suction out, ready to go.
And everybody else on scene was like, yeah.
Right.
It's RSI.
Yeah. Okay. Yeah. I mean, yeah, basically. I mean, the new person, he really didn't have anything to say. Mm-hmm. He was just, he was just there to assist and drop some drugs and such. And the 2 on the ambulance were pretty checked out. Mm-hmm. What we could have done, best case scenario, get in the back of the ambulance, start driving up and preparing for the intubation.
Yeah. And that's the part that I've noticed it's really difficult for. And I think it's, no offense, Daniel, I think it's a generational thing.
Well, thank you.
In a lot of ways.
I am a baby boomer, and I appreciate that. Greatest generation.
Yes. The thing that I have been on calls with 20-plus year vets where we're having a conversation about why we shouldn't intubate and why it's good to just keep their SATs up and go the extra 3/4 of a mile to the hospital and not stop and intubate.
Right.
And those arguments get a little heated. And I truly think that's in the best patient's interest, right? I mean,
it absolutely is. I have actually pulled over a 1/4 mile away from the hospital to pop a tube in.
We've been in the ambulance bay.
Oh, you got me beat.
I mean, not to one up you there, but I'm asking myself, why are we doing this here? Yeah. And then you get the trauma surgeon, you get the ER doc, you get the
and they're saying,
IC
what the
team.
Are you doing right now?
And they're going, really, guys, right now? Yep. And like, the doors are wide open and, someone's got a laryngoscope in this person's mouth. And I mean,
and they're probably not pre-oxygenated. They're probably not resuscitated, medicated appropriately.
Yeah, I mean,
I agree with you about it being a generational thing. I think
in some ways, yeah. I don't want to paint with a super broad brush, but in some ways,
that.
Yeah.
Well, see, I became a paramedic in 2002.
Uh-huh.
And so I do remember thinking like, oh, I can't show up at the ER without a tube, an IV, C-spine, or they're going to judge me.
Exactly.
Right. But I've been a nurse for a while now, and I've been on that other side at the trauma center receiving the patients, and nobody cares.
Yeah.
They care if the patient's got an airway or O2 sats or blood pressure,
Right.
but they don't really care what you have or haven't done in the field because everybody knows you're doing your best.
Right.
But I do remember feeling that pressure. I can't show up to the
Absolutely.
to the trauma center without this person being intubated.
Yeah.
And then they intubate right when they get there, and you feel
Right.
like shit, right?
Yep.
Well, so,
But when they intubate and they've got all the anesthesia and RT
they're all
and
set.
oxygen and the rapid infuser,
Yeah.
they're in a better situation to do that than we are. And if
For sure.
we can deliver them with a blood pressure and a SAT and some brain function, that's a win.
Right.
absolutely.
Yeah. But I would have never thought that when I worked in the field.
No.
The thing that I've kind of, going back to that mental component of all this, the thing that I've learned to enjoy far more than getting a tube, the feeling of someone coming back to the fire station and saying thank you,
Right.
and giving you a card, or, just saying thanks.
Right.
Those moments are, I mean, I'm getting goosebumps now just talking about it. Like it's really, really cool. And you know that you did your best, you made a difference, and now, a month later they're walking, talking, and
Right.
saying thank you.
And in the sequence of their emergency, you did your part.
Yes.
You got the patient from the scene to the hospital.
Mm-hmm.
You didn't stop and have to get an airway and do this and do that.
Yeah.
What's the thing about stopping to get an airway? You can't do an airway while you're driving? Or just because there's only one
It's a
person
little
in the back?
judgy sounding, Holly.
I know, I'm just wondering.
No, you're absolutely
Because
right.
there's only one person and you got to get out and help.
No,
No.
because you'll have more. It all depends on where you work, right? But there are some people who have to have a completely still ambulance to either start an IV or pop an airway in.
Yeah.
I know. You just saw Holly's eyes right there.
And that is truly a paramedic to paramedic thing. I've been driving where people are like, okay, I'm going to get an IV. Go ahead and stop.
yeah.
Like,
What?
dude, your job is
Right.
doing this in the back of a moving ambulance.
Right.
That's your job. And their argument is going to be, well, it's not a critical patient. I should be doing this as
Then why are you doing an IV?
comfortably as I can.
Exactly.
And it's like, I can go back and forth with these people a bunch, but in my brain, you should be able to look up the front of the ambulance, know where you're at in your district, and say, okay, the roads are crappy here. I'm going to wait a minute. Or the roads are good here. I'll just put one in real quick. But the idea of stopping the transport
Right.
for 4 minutes to get an IV and secure it and everything else.
Could you imagine us in the helicopter? Hey, can you land this thing real quick? I gotta grab an IV real quick.
That wouldn't go over well.
No, it would go over well.
Oh, man. So let's go back to airways in general. And I want to touch on, we started with the case, but I want to go more into the educational side, the classroom component of this. So we've learned, or we've been talking about what we shouldn't be doing, i.e. pulling over, seconds away from the hospital and doing this,
stuff
right?
for your own ego.
Right. Doing what's truly in best in the patient, can I talk?
Best interest of the patient.
Truly what is in the best interest of the patient.
You went to a 5-star school, right?
I did.
Okay.
Yeah. And I'm talking.
Mine was mail order, so.
Yeah. But Dan, talk to me about what good checklists in your head should look like for RSI or for intubating.
So for the first thing in my checklist in my head is get out the checklist, because I'm stressed at that time and I'm trying to manage a full scene and a crump patient. So like Holly said, that checklist needs to be out. So it kind of resets yourself. It slows it all down. It calms everything down. And then everyone is on the same page.
Mm-hmm.
And then you're not going to read through the entire checklist. Like, okay, what are our indications for intubation today? If you have the checklist out, you probably got that one covered.
Yeah, for sure.
So you hit the high points. Is the patient pre-oxygenated? Is the patient positioned? Is the patient resuscitated? And what I mean by resuscitated is you want to make sure that their sats are as high as you can get them and they're denitrogenated. You want to make sure their blood pressure's high enough that they're going to perfuse the brain during the intubation. And if not, resuscitate.
Yeah.
Fluids, pressors, have all that stuff out. So at where I work, our fourth drug we always pull out regardless is push-dose epi. Even if the pressure is 150, we'll pull out. Well, it doesn't mean we give it, but it's all set and ready to go.
Yep.
And that's why we're always critically thinking, every single patient, not the algorithm of Airway. Because you think of the algorithm of Airway, that's when you're in paramedic school, you have that mannequin in front of you and you're going through the steps.
Right.
Now you have a real person who has a beard or is super fat or is very anterior.
Has a distracting injury.
And they're not laying on a table.
Right.
At the exact height you need them to be.
Yes.
Right. Exactly. Or you have a partner who's chirping in your ear, or you've got all these stressors that are going on. So where was I on this? So resuscitation.
Talk about checklists.
Thank you. Checklist.
Yeah.
I need a checklist for this podcast.
Get your checklist out, please. Yeah.
And so I get that checklist out, and it's like you start speaking and everyone shuts up and everybody knows where you're going. And so it goes down the line and to the point where you have a failed airway plan. And that's a horrible way to say it, because if you, like Holly said, if you deliver a patient to the trauma bay without an airway, but at least they're maintaining their airway, you're doing good jaw thrust, you've got adjuncts in, that is a good airway management, because you have critically thought that patient. Like, I don't want to, I'm too close to the hospital, I'm not going to RSI. Or this patient, if it goes shitty, I don't have a backup to fix this.
Right.
So on our checklist, we have a failed airway plan. Like, okay, I'm going to intubate once. If I don't get it, I'm going to pass off my partner. I'm going to let him do it once, or she. If they don't get it, I have the king or the iGel. That doesn't work, we'll bag the patient if we can adequately bag the patient. If not, I'll cric the patient, and here are my landmarks. And that announces to everyone your plan. There's no surprises, like, and it gives myself permission to do whatever I have to do. Like,
are you in the habit of marking your patients for crics when you're doing an RSI?
Sometimes. The only thing is people move.
Right.
And so you can have that. I'll always touch it and point to it. And that works really well. And then that just relieves all the stress in the back of the ambulance.
Right.
And I like what you said, which was, if we can bag adequately, if you can get a good seal and you've got oxygen exchange, you're going to intubate. If you can't intubate, you're going to put in a supraglottic airway. And if you can't do that, you're going to go back to bagging, because you can bag.
You can bag.
Instead of going straight to cric.
Right.
Yeah.
Cric, I think of a cric as I can't oxygenate, can't ventilate.
Right.
So I'm going to cric. But if you can do that with a BVM.
Right.
So I like how you put BVM back in the algorithm.
You got to put it back in the algorithm, right?
Before cric.
Right.
And sometimes you just have to skip right to cric. I'm not saying not to do it.
For sure.
But don't forget, BVM is good airway management.
For sure. Absolutely. The thing that I always think about is, where does this have to get to for me to pull the trigger on a cric? And I like to set trigger points for myself. And the reason that I use a checklist, or I go to a checklist, and I might not, like you were saying, I might not look at the thing very thoroughly because I know it. Not all the time, but sometimes. But the reason I go to it is because it resets where I'm at.
Right.
I've just learned we're on the scene of a whatever patient that needs a whatever, intervention, and your brain and your body start, dumping a little bit of adrenaline, and you start getting a little amped. And when you catch yourself in that, and you can step back and say, okay, time to check myself, check my breathing, check my tone of voice. If I'm using a quieter, calmer tone of voice, it always helps the situation. It never makes it worse.
It brings the stress in the back of the ambulance way down,
Absolutely.
doesn't it?
And if I'm using a voice that is giving lots of directions and is a little bit sped up, and you can sense that
Disorganized.
Yes, that little anxiety undertone.
Yeah.
Everybody picks up on that, and it snowballs really quick. And so I like the checklist thing. I've always liked, because it forces me to step back, look at something, take my brain off of what I've just seen, what I'm worried about, what my concerns are, and it helps me get my drugs out in the right order, get that thing going, and then I start to formulate, okay, trigger points. I'm going to have a backup airway device, in case this thing goes not as smoothly as I thought. And, okay, worst case scenario, I've got my cric kit out, and I'm ready to go if I need to do that. haven't had to get there with an RSI in the back of an ambulance per se, but knowing that I have that, when you have plan A fail, you have plan B and C ready to go. That provides that comfort that allows that mental component of what you're doing to really take you to the next level and get done what you need to get done or what you're trying to accomplish in the back.
And having the checklist, it really does put everyone on the same page. And it gives you a way to be direct without worrying about hurting people's feelings.
Right. We're always worried about feelings.
If I've got my list out and I say, have we pre-oxygenated? That's pretty direct, but I'm reading off my list.
Yeah.
And then, like Dan said, everybody knows what the plan is. It takes the stress level down. It gets quiet. It's awesome. And to be honest with you, in however many years I've been in EMS, never used a checklist, ever.
Yeah.
Until the last couple of years.
Right.
And because I've made that my practice.
Yeah.
And it's really hard to change.
And we're still fighting to use it.
Yeah, it's hard to change all the bad habits that I have over all these years that I've honed perfectly.
Great job.
Yeah, right.
So, Steve, back to the Craig thing. And this, think of a pilot.
Yep.
Think of a pilot who says, I've been flying a lot, and I have used my parachute 6 times. Do you want to fly with that guy?
Absolutely not.
Probably not. Well,
Yeah.
I've been a paramedic for 30 years. Wait, 25 years. I'm trying to make myself look better than I am. 25 years, and I've cried 6 times. What does that say?
You suck at airway management.
That's exactly what that says. So, the only good thing about that is now when I walk into a back of an ambulance, I automatically think I am going to crack this patient, because I start up here where I'm going to crack this patient, and then I work my way down. There's nothing worse than getting in the back of the ambulance thinking that it's a nothing call and have to start climbing that ladder and saying, oh, I got to try this. I got to try that. And then you get to the crike point. By that time, they're coded.
Yeah.
If I start at thinking I'm going to crike and then work my way down, just become more and more disappointed as the call goes on, then
So
it's a problem.
you just brought up something that reminded me about something in education. So there's 2 ways that instructors typically grade. They grade you on day 1, you have a 0 and you earn that A, right? You know, each assignment you get a 90 plus and you end up with an A in the class, or however it averages out. Or there's that other school of thought that says everybody on day 1 has a 100%, and you have to work to lose it if that's really what you are trying to do. So you hand in your assignments on time and do a good job, you maintain your A. But if you start to slip, then you go down that cascade, right? So yours basically on that second school of thought with everybody's getting a crike today.
Right.
You've got to prove to me that you're losing it. And then when you drop down to a 70,
Right.
it's a typical RSI for you and you're not doing anything super special beyond it.
Right.
Interesting, Daniel.
Yeah.
It's pretty impressive. Yeah, I like that. Okay. So where do we go from here when it comes to talking about the classroom side of things and where education should be with RSI? And it sounds like we've identified or seen a lack of education on using your checklist, maybe even the mental side of things where you're checking your ego and you're not letting that dictate which procedures you perform. But what else?
I tell you, you have to be able to change. For so many years, I was unwilling to change because I fear change.
Everybody does.
A lot.
Yeah.
So if you cannot start changing your practice by way where the literature is going, the studies are going, then you are going to be a horrible clinician.
Yeah.
And I see that a lot, like the old people, like you're talking about, like myself. If you don't listen to podcasts, you don't re-engage in EMS because EMS is dragging, right? It just grinds on you because you go on the same people, and then you get that critical call, and then
Catches you off guard.
Right? And so you have to, every day has to be a new day. It has to be, how can I better myself today?
Yeah.
The longer I do this, the more I know I don't know, and it scares the out of me.
That is so true. The longer I'm in this business and the more in depth we get, like from EMS to the ICU to the ED to flight medicine. The longer I do this, the more I realize I don't know.
Yeah.
And it's really humbling to think like how lucky I've gotten over my career.
Right. And
Like,
what we
man,
don't
if
know.
I would have known that back then. But going back to your question, some of the things that people I think miss is, don't forget when you push paralytics, you take away all vascular tone. So if they've got a shitty blood pressure at the beginning, and then you take away all the tone that their blood vessels have to keep that blood squeezed, they're going to code.
Right.
And I don't know how many times in my career we've been pushing meds and say, well, you know, hope we don't kill this person.
Yeah.
Right. Yeah.
But it was never brought up to us as good clinicians to make sure you resuscitate that patient. Give the push dose epi, give some blood, give fluids or whatever you carry before you push those paralytics.
Right.
Because we're all so concerned about getting the tube. Oh, their blood pressure is bad. Their sats are bad. We need a tube.
We need the tube right now.
We need the tube right now, which you don't
Right.
actually need the tube right now. But I think those are the things that I wish I would have known at the very beginning of my career, or would have been impressed on me by my mentors and preceptors and partners over the years.
Yeah.
That those things are way more important
Mm-hmm.
than getting the tube.
So, Holly, I think you had a case we want to go over with RSI.
Oh,
wh-
the one I didn't RSI?
Yeah.
That's perfect. I like it.
Okay.
The non-RSI, RSI.
This was actually just a month ago.
Okay.
Had a really bad MVA, long extrication. We arrived on scene as they were, I was on the flight crew that day, so we arrived on scene as they were extricating this person. He was screaming at us that he was going to die, which I agreed with.
Yeah.
And, you know, we hadn't really done anything. So I pull him out. Their first question was, do you want to RSI here or in the ambulance? And, you know, I was like, well, let's at least do a rapid trauma assessment first. And so I was doing my rapid trauma assessment. And as I pulled his sweats down to check his pelvis, blood started squirting at me. And I was like, oh, shit, that's not good.
Yeah.
And I was working with a really strong partner that day, and we both looked at each other and at the same time said, he needs a surgeon.
Mm-hmm.
And keep in mind, we have a 10-minute flight to a level 1 trauma center.
Okay.
We could not get a radial pulse. He did not have a blood pressure, but he was screaming at us, so he was alert and oriented enough to tell us he was going to die, which, again, I agreed with.
And that's what's keeping him alive, right?
Yeah.
Yeah.
So I almost got caught up in it. I really was like, well, we should probably RSI in the ambulance then, because there's suction and all the other good stuff in there. And then quickly, I was like, he needs a surgeon. He does not need an airway right now.
Right. We got to go.
And so simultaneously, we're getting an IO to give fluids, and we made the decision just to go. So we were on scene for about 7 minutes before we lifted to go to the trauma center. And en route, it's difficult at best to intubate.
Right.
You know, so we were thinking ahead that if we do need to intubate this guy, if he loses his airway, we just had a king airway out. That was going to be our first attempt at a good airway because we probably wouldn't need to RSI. And it's a pretty simple procedure.
Right.
So we got him to the trauma bay. We gave him a unit of blood on the way. And we had our push dose epi out because I figured we would need it, which we didn't. And when we got to the trauma bay, they did RSI him right away, and his pressure dropped from 90 to 60. He was on the rapid infuser for blood administration, and they could not get his blood pressure back up for about, 35 minutes. And he went straight to the OR with an iliac artery laceration.
You would have killed him on scene.
We would have killed him
Absolutely.
if we pushed paralytics. And they darn near killed him in the trauma bay, but with a rapid infuser, you can just infuse massive amounts of blood to overcome that blood pressure. And that was one of the first times I've delivered a dying trauma patient to a trauma center without a definitive airway, if we want to call it that. But he had great sats. He was still screaming at us. And he had a blood pressure, and that was the best call I've ever been on. I was so proud of myself for not intubating.
I tell you, 10 years ago, I would have said, you were a chicken, you were scared.
No.
But now that excites me so much that you didn't do anything.
I know.
Except transport.
Right. We resuscitated, we pre-oxygenated, we did all of the things we needed to do.
And prepared just in case.
And we were prepared just in case. But, if we had had a 30-minute transport.
Different story. Yeah.
I don't think I would have done anything differently.
Really? Okay.
Yeah. I think we still would have loaded without an airway.
Mm-hmm.
Right. Just done it.
Rapid infused blood and fluids. And reassessed.
Yeah.
So just so everyone knows, tell us why he was maintaining that blood pressure.
This guy is, I think while he was trapped, somehow he had this huge puncture wound in his left lower abdomen. And it wasn't actively bleeding. It didn't look like it was bleeding. Had I not pulled his sweats down to do my assessment, I might not have noticed that he was bleeding to death. So, when that happens, your body releases all kinds of catecholamines. You've got epi and norepi. You want to perfuse your brain, of course, so all your vessels squeeze. Mm-hmm. And he had a really good blood pressure because I think he was in a ton of pain. He had a huge catecholamine dump, and we were giving him blood.
Right.
So we were replacing what came out of the wound that we packed very well. Mm-hmm. And then I put the big, huge, bulky dressing on top of it and used the spider straps to push it down to create a pressure dressing. Mm-hmm. So I think we did occlude the artery pretty well because it was right up against the pelvis. Mm-hmm. But anyhow, catecholamines, blood, fluids, airway. We didn't screw with his normal physiology. Your body's really good at
keeping yourself alive.
Right.
Mm-hmm. And so I'm stealing this from someone else, but the analogy that I was told that finally kicked into my head is like in Holly's patient right there. If you were to go inside his head, the music that would be playing would be 9 Inch Nails. Just, you take that away with etomidate or ketamine and then sucks them, then you have Bob Marley just kind of swaying around, and his blood pressure is going to dump.
Mm-hmm. Yep. He's all relaxed now.
Nice job.
I don't want that.
The thing you brought up that was a funny reminder for me was stupid questions on scene and how annoying they are. So not necessarily that the person who asked the question about RSI here or RSI in the ambulance was asking a stupid question. They thought the guy needed a tube, so I get that. But there's been numerous times, and I'll share an example, of where a really dumb question or a really dumb statement.
Blood sugar.
Yeah. It truly stops a lot of good progress at times. And here's my example. So we're in a kind of on the outskirts of our town, highway area, and 2-lane highway, like 45, 50 mile an hour zone, and head on, guy drifts in the other lane, boom, head on, kind of on that angle, right? So it spins the cars, and one guy's trapped in the vehicle. We show up on scene, and we've got everybody coming, a couple engines, a command rig, 2 medic units. We had a lot of people in place to go on a call when this one came in. So we get on scene, and I'm met by this. I'm sure he was a lovely guy.
I'm sure
he had a volunteer fire department shirt on. I'm sure he thought he was doing well by throwing this out there. Walking up, checking the patient, trying to do, we call it inner and outer circle. Inner circle focuses on that, the patient and the vehicle. Outer circle focuses on the scene, right? And making sure that we keep a bigger picture on it. But I'm inner circle, so we're worried about the patient, worried about the car, making sure we're stable and everything. Talking to the patient, and this guy's in bad shape. He's not doing so well. And I'm trying to get out to my crew the stuff that I need inside so that I can treat him while I'm in here while they're cutting him out. And this guy keeps coming up to the vehicle yelling, "You need to fly him. You need to fly this patient." And it stopped. So first off, one, I got to find someone to get this guy out of here, right? Because he's not helping and he's making it worse. I tell him to back up, and then we get a police officer to pull him back. But his stupid statement made me think, well, maybe we should fly him.
Right.
And
this is coming from a bystander.
This is coming from a guy with a volunteer fire department shirt from who knows where, if he's even active or was 25 years ago. He's yelling this at me, right? And so I'm thinking to myself, well, maybe I do need to fly him. But I had to take that like 20 to 30 seconds to go,
right.
No, Steve, you're like 2.5 miles from the hospital down a straight road, and you don't need to fly this patient. It's going to take the helicopter 15 or 20 minutes to get here because you didn't activate them, and they're going to be starting from. And so I'm going through like why that's a bad idea. And I finally had to tell myself, yeah, you don't need to keep coming up with more reasons why it's a really dumb idea.
Right.
Just stop that thought process and focus on your patient who's in bad shape.
But it's really easy to get sucked into that.
Yeah, because you have to create, here's why I'm right. This, and this. That guy doesn't know what he's talking about. But hey, Steve, maybe clue in on the fact that you've got a guy who's, you're holding inline stabilization on, who's starting to slump.
Yeah,
He's not doing good. But that question about RSI here, RSI in the ambulance, it's kind of like when you give your kid two choices, like, do you want goldfish or do you want Cheez-Its? You can't have both. What do you want?
Right.
And it's like, well, what if I want ice cream? It's like, but crap. Right. And then it just takes your thought process out of it and puts you in a weird spot. And I hate dumb questions on scene. I hate dumb statements on scene because it pulls me out of my funk.
If Holly wasn't strong, she probably would have RSI'd on scene because she would have been sucked into that.
Right. Or if I had a different partner, they may have said,
hey, Holly, we should
option one or two, Holly. Option one or two.
Right.
And it's like, well, neither.
Right. Yeah. And that the patients would be dead now.
Right.
Yeah.
So,
but to their credit, on the ground, that's 45 minutes to an hour transport. Code 3.
For sure.
So in their minds, that's what they're thinking.
That's their usual.
Whereas my transport's 10 minutes.
Right.
So it worked out really well.
Yeah. Cool. Well, I hope we went over some good stuff today. I feel like we touched on the reasons why it's important to use checklists, the reasons why it's important to have good conversations on scene and to have the ego drop and do what's best for the patient. But yeah, good stuff.
It is good stuff. The thing is, I'll go to work tomorrow and I could get sucked in on the same stuff. We have to be super strong and super confident, but listen to what someone else is suggesting, but absolutely know your protocols, know what's best for the patient, critically think each and every patient so that you're able to withstand those temptations like Holly did.
Yeah.
And yourself, sir.
Yeah. Oh, thanks, man. Yeah.
Change our opinion of airway management. It looks a lot different than just an ET2.
It's not an ET2, right?
Yeah, it's like a hazmat incident. Sometimes the thing you do is you don't go running in. You step back, you get your information, and then sometimes it's do nothing for a long time.
A win,
and that's a win. And so we need to kind of reframe the way we're thinking about these things. But let's leave it there, and we'll sign off. But thanks for joining us today, guys, and we'll look forward to the next one.
Yes, sir. See ya.
Thanks.